Come on. Come on. People wonder why we hate Zoom so much. Because it does this to our computers. Okay, it took 10 minutes to get Zoom started. And everyone wonders why we hate Zoom so much. All right, Wednesday, we have a test scheduled. Softball just informed me they don't have an issue. Baseball? Yeah, I don't think you do. But if any, I don't know if your schedule's been changed or not. As far as you know, you're okay. And let's see. I can't think of any other sports that would have an issue. Katie, golf? No, you're good. Okay. Track, Rem? No, you're good. Okay. Then the test will be Wednesday, and the format, excuse me, will be the same as the last exam, and it will be through hypertension, which we'll hopefully finish today. Your case studies, mostly graded. They're up here. I was going to hand them back, but it took too long for me to get Zoom started. So I'll hand them back maybe afterwards as time permits. All right. So we're on diuretics, and we will plow through as needed. Let's pray. Lord, we thank you for warmer weather. We thank you for focus. We pray now as we emerge from that, you help students use their time wisely, get ready for the upcoming test. Thank you for the chance to learn today. In Jesus' name, amen. All right, so we looked at beta blockers. Now our subject at hand are the diuretics. Remember, diuretics decrease blood volume. Because they decrease blood volume, they decrease systemic vascular resistance. So whereas your beta blockers decrease cardiac output, these decrease systemic vascular resistance. There's three main diuretics that are used in blood pressure control. Thiazide, thiazide-like diuretics, loop diuretics, and potassium-sparing diuretics. Carbonic anhydrase inhibitors are predominantly used for high altitude sickness. High altitude sickness. They get rid of bicarbonate, they get rid of carbonic acid, so they get rid of CO2. Because they get rid of CO2, they prevent the hypercapnia that is a problem at high altitude. That's what they're used for. The doctor will not give you a prescription for carbonic anhydrase inhibitor. They are too risky to use long term. You use them kind of one-shot deal. So you have a list in your handouts of the different types of diuretics. So the loops, remember, you have these four. Ethacrynic acid is the one that doesn't have sulfur. If you have a sulfur allergy, you can't take these, but you can take ethacrynic acid. Torsemide is the one with the longest half-life. And then the thiazides and thiazide-like diuretics. Hydrochlorothiazide is definitely the one that's used the most. It's very cheap. And then chlorothiazide, chlorothalidone has a longer half-life. And then metalazone. Metalazone is useful if your patient has decreased renal function. These in general are drugs that work very well. They're not very expensive, and they're pretty widely used. Potassium-sparing diuretics you will use in addition, usually, to either a thiazide-like diuretic or a loop diuretic. Those will increase potassium levels with these. Typically, you lose plenty of potassium. So if you put a potassium sparing with one of these, they will tend to equal each other out. With loop diuretics, remember, you lose a lot of fluid. So dehydration becomes an issue. So does loss of electrolytes. So loss of magnesium, loss of sodium, particularly if you see patients in retirement homes. If any of you have ever worked in a retirement home, so-called hyponatremia is pretty common. In fact, it's probably the most widely recognized electrolyte deficiency in retirement homes because residents there are being fed low-salt diets, and then if they're on quite a few diuretics, they're losing a lot of sodium and they don't replace it very much. Also, old age causes you to not recognize when you're low on sodium, just because of lack of sensory issues and things like that. Carbonic anhydrase inhibitors, there's just two, acetazolamide and methazolamide. And notice those end in zolamide, and they're used again for high altitude sickness. One more thing. These are mainly oral. There's an IV version of furosemide and an IV version of bumetanide. I don't think there's an IV version of ethacrynic acid. I think that one's strictly oral. Same thing with torsemide. I think that one's just oral. Thiazides are largely oral. For emergencies, there's the IV version of hydrochlorothiazide. The others, I don't think there are IV versions of that. These are oral. There aren't IV versions of those. So again, these work in the kidney. These work in the kidney. And the adrenal gland up here that secretes, for our purposes, several hormones, but the adrenal cortex, the outer cortex makes steroid hormones. So it makes glucocorticoids, cortisol, cortisol-like molecules, and then mineralocorticoids. The major one by far is aldosterone. But these work in the kidney, these diuretics. So quick review. Loop diuretics work in the loop of Henle. Potassium-sparing diuretics work in the distal convoluted tubule and the collecting duct. Thiazides work in the distal convoluted tubule. Carbonic anhydrase inhibitors work predominantly in the proximal convoluted tubule. Loop diuretics inhibit the sodium potassium chloride transporter in the thick ascending loop of Henle. Carbonic anhydrase inhibitors inhibit the soluble and the membrane-bound carbonic anhydrase in the PCT cells. That enzyme is ubiquitous. Thiazides, thiazides inhibit the sodium chloride transporter found in DCT cells. Oh, incidentally, don't think I said this about thiazides. When you pump sodium and chloride into the DCT cells, another ion you also will reabsorb sometimes is calcium. When you inhibit the sodium chloride pump, you reabsorb more calcium. So thiazides actually increase calcium resorption. Now, why is this of interest? This is of interest because thiazides can be protective against osteoporosis. That's particularly significant in postmenopausal women who are the ones most prone to osteoporosis. So they increase calcium reabsorption because of this linkage between calcium reabsorption and sodium and chloride reabsorption. The more sodium and chloride you reabsorb, the less calcium you reabsorb. And then the potassium-sparing diuretics, there's two types. One of them, the steroids, spironolactone and eplerenone, they antagonize the aldosterone receptor. And then the other two, amiloride, triamterene, they inhibit ENaC, the epidermal sodium channel, ENaC. And ENaC is the gene that encodes ENaC is induced by aldosterone. So if you inhibit that channel, you inhibit the reabsorption of sodium. Therefore, more sodium stays in the filtrate, or water stays in the filtrate, you lose more water. You keep more potassium because the sodium is exchanged for potassium normally. So your diuretics will decrease blood volume. They therefore will decrease extracellular fluid volume since you have an exchange between intravascular and extracellular volume. So they're good for edema in general. And they will decrease blood pressure. And that, of course, is our purpose, but they can also be used for things like ascites or things like increased intracranial pressure or pedal edema, where you have swelling of the ankles, things like that, because they're used to get rid of extra fluid, and they're good for that. So your big adverse effect is your electrolyte disturbances. Biggie definitely is potassium. That would be number one. That'd be the number one thing you look at. And then magnesium, also sodium, and then potentially calcium as well. They can increase blood glucose levels. Part of that is that as you lose more liquid, glucose becomes more concentrated, but also because you're losing liquid, the liver will tend to produce more glucose. So they can raise blood glucose levels. In some people, this is slight. In others, it's more substantial. So in a diabetic patient, you want to use these with caution. They can cause hypotension. Therefore, you'll get some postural or orthostatic hypotension. Lipid blood levels will go up with diuretics. Thiazides cause photosensitivity. Ototoxicity is seen in loop diuretics, but it's reversible. Once you get off the drug, that goes away. And then because these are secreted into the kidney, and the transporters that secrete them into the kidney are the same ones that secrete uric acid into the kidney, they compete with uric acid for secretion into the kidney. So they will raise blood levels of uric acid. So they cause hyperuricemia. And hyperuricemia can lead to precipitation of uric acid crystals at joints, and we call that gout. So they're contraindicated in gout. And I don't know if you've known anyone with gout. Uric acid crystals, you see them under a microscope, they're like needles, and they do a lot of damage at a joint. And people with gout, the burning, painful sensation they have at joints is excruciating, truly excruciating. Few words about potassium abnormalities. So here'd be a normal EKG, just some things to look at. You look at the T wave. The T wave is usually on par with or just a tad bigger than the P wave. If, however, you look at someone with hypokalemia, you'll notice the T wave tends to be pushed down. And then there's this other wave, which is usually undetectable. This is called the U wave. The U wave gets much more prominent. And that is a sign of hypokalemia. So the ST wave gets pushed, ST interval gets pushed down. The T wave gets pushed down. The U wave gets pushed up. And with hypokalemia, that biphasic T wave, where the T wave's down, U wave is up, that's classic hypokalemia in an EKG. You'll tend to see this most prominently in the leads that cover the left ventricle. So leads 3, 4, and 5, typically. Patient will usually be weak and have a sick feeling as well. Heart rate will usually be irregular. Early hypokalemia, the heart rate will be fast, and then it might start to become irregular as well. So the biphasic T wave, that's a big thing you're looking for. Now, with potassium sparing diuretics, you can have hyperkalemia. And with hyperkalemia, what you're going to see is the tidal T wave. So the T wave gets really big, and I call it the tidal T wave. And so hyper, too much, you have too much T wave. So that's my dumb way of remembering it. So you have the tidal T wave, and you can see here in V4, the T wave is, yeah, pretty nasty looking, but it's essentially V2 through V6. All of them have T waves that are way too big for their britches. And that is a hallmark of hypokalemia, the tidal T wave. Weakness, paralysis, chest pain, rapid, sometimes slow heart rates, usually GI issues as well. But these can be very general, very nondescript. The biggie is with EKG, you see that big T wave, that's hyperkalemia. Yeah. So if you have a patient who has congestive heart failure, where you're on drugs that increase serum potassium levels and also potassium sparing diuretic as well, that patient's at risk for hyperkalemia. So very often they'll be on other medications that spare potassium as well, like ACE inhibitors, ARBs. When we cover congestive heart failure, we'll see there's this medicine called Entresto that includes 2 drugs that spare potassium, but they have to be, in addition to being on Entresto, they have to usually be on a potassium sparing diuretic as well. And so those patients are at risk for hyperkalemia. Now, usually if you have patients that are on thiazide and a potassium sparing diuretic, or a loop diuretic and a potassium sparing diuretic, it's not an issue unless they're taking potassium supplements or they're on something else that tends to spare potassium or something like that. Or they're on digoxin or something like that, which digoxin is a pain in the butt because it's got a narrow therapeutic window and a long half-life, and it interacts with everything under your armpit. And it's a pain. But it's a great drug if your heart needs more oomph, because that's what it does. It gives oomph. And okay, king of stupid mnemonics, think of an ox digging a hole. Dig, oxen, get it? Okay, it's stupid. I know it's stupid, but you'll remember it, right? Because it's stupid. So that's another drug also that can mess with potassium as well. So very often you have to get rule one, medical history. Get a medical history, find out everything wrong. And that will tell you essentially if they're at risk for this. Okay, some compelling indications. They're quite good for isolated systolic hypertension, which you tend to see in older men. That is treated quite readily by diuretics. Congestive heart failure, they're a must. In fact, they're one of the 4 pillars of congestive heart failure. If your patient's at risk for osteoporosis, thiazides, are a good possibility because they spare that calcium. And if you have a patient who's diabetic, depends how well they control their blood sugar, then you want to use these drugs with caution, contraindicated in gout. And many of these are contraindicated in people with renal insufficiencies, albeit there are some drugs you can use in patients with renal insufficiency. Others are simply contraindicated because they have to be secreted into the kidney in order to work. Now, turns out African Americans do not respond well to ACE inhibitors or ARBs. The reason for that is that on the average, African Americans tend to make low levels of renin. So if you give them an ACE inhibitor or an ARB, 8 times out of 10, they won't respond to it. Also, their tendency to develop angioedema is higher. So on the average, African Americans are not treated with ACE inhibitors and ARBs, or renin inhibitors for that matter. And it just has to do with the genetic heritage that you carry with you, essentially, as a member of a particular human lineage. So this comes out in healthcare. They're not going to respond to certain drugs as well as other people. But turns out African Americans respond extremely well to diuretics. They do very, very well on diuretics. And consequently, if you have an African American patient with high blood pressure, you might want to consider a thiazide diuretic first before you consider anything else. Now, the other beauty of diuretics is that they tend to play well with other antihypertensives. So if you need to combine antihypertensives, diuretics are one of the best drugs to combine with other antihypertensive drugs because they will tend to not have cytochrome P450 interactions because they're excreted by the kidney. And they will usually work well in a combination of some sort. So when it comes to combining them, they not only work well, but they will tend to show synergistic effects. Their efficiency does drop, however, once your renal function becomes seriously impaired. So you want to try to protect renal function as much as possible if needed. All right, any questions about diuretics Use of diuretics. Diuretics in general. Yes, Allison. You mean, does your kidney become dependent on diuretics? No, no, that's pretty clear. There was a report in Journal of Nephrology 4 years ago that suggested if someone's on thiazide long-term, by long-term meaning decades, that there are changes that the kidney undergoes that are thiazide-induced changes in the kidney. That paper essentially, after it came out, was reviewed by other nephrologists and said, yeah, you see this in some patients because it depended largely on kidney tissue samples from biopsies of people after they were dead. People volunteered essentially have their kidneys looked at. And they said, that's the case, yeah, but if you look at living patients and look at biopsies of living patients who've been on thiazides for a long time, that doesn't seem to be the case. So the answer to that question seems to be no. Once you get off them, your kidney still functions just fine. All right, now what about ACE inhibitors and ARBs, which we'll consider together, since mechanistically they tend to be kind of similar. So your ACE inhibitor prevents the conversion of angiotensin 1 to angiotensin 2, and your ARBs just prevent angiotensin 2 from binding its receptor. And so by using this kind of flow chart here, you can see that you antagonize both angiotensin 2 production or activity. You're also going to antagonize aldosterone and its function. Consequently, these drugs in general tend to preserve kidney function in people with conditions that tend to be hard on kidney function. So if you have a patient with hypertension, hypertension tends to be hard on the kidney. ACE inhibitors will tend to preserve kidney function. If you have a patient who's diabetic, diabetes tends to be hard on the kidney. These drugs tend to preserve kidney function. So these drugs have a renal protective property. Because of that, they're very widely used. Very, very widely used. And this simply shows you essentially all the things that the AT1 receptor does. It's very clear that chronic activation of AT1 also causes a pro-inflammatory environment in blood vessels. And that pro-inflammatory environment in blood vessels, number one, increases the risk of atherosclerosis. Number two, also increases the risk of intravascular clots. Did you guys hear in the news? I don't know how much news you guys consume or where you get, well, you get your news probably from your feeds on your phone, if my reading of culture is accurate, which it often isn't. Is that fair to say you get your news from your phone feeds? Okay, I'm not too far off. So at least half of you say, yeah, that's the case. Did any of you read that Europe had halted the distribution of the Oxford AstraZeneca vaccine because of their blood clots? So the report was published by European Medicines Agency and then the British Medical Healthcare Products Regulatory Agency. And the number of clots was 1 clot per 1.5 million shots that were given. And then when you compared that with blood clots that occur in normal cases, it's about half the rate. So essentially, if anything, these shots are protecting against blood clots. When you look at the rates, again, it's a scare tactic of, oh, somebody got a shot, and a few days later they got a clot. Oh, gee, it must be the shot. Well, maybe it's something else. Were they on birth control? Do they have heparin? Could it be HIT? Were they aged? Did they have high blood pressure? Did you consider all these other factors? And the report that was just issued by the MHRA and also by the European Medicines Agency said, is there evidence that the vaccine causes blood clots? In a word, no. Get your jabs. COVID-19 is much more deadly than the vaccine. So now, after being delayed for a couple of weeks, now they're re-releasing the vaccine and people are screaming for the vaccine. And yeah, the European Medicines Agency fouled this up 7 ways to Sunday. Europe is way behind in vaccination, and now they're experiencing a third wave. It's like, guys, could you have cocked this up any worse? It's just, it's ridiculous just how badly they cocked this up. Okay, off my soapbox. Anyway, so that's why these drugs can have such terrific long-term effects, because they can prevent all the things that chronic AT1 activation does. Oh, incidentally, so what's a receptor for COVID-19? Anybody know? ACE2. ACE2 actually binds angiotensin 2, and it converts angiotensin 2 into a smaller version of itself that's actually protective against the effects of AT1. So when you remove the ACE2 receptor from the surface of particularly cells in the lung, now those cells become subject to the ravages of AT1, and that's why in COVID-19 you have increased blood clots in the vascular system. Little tidbit of worthless information for you. Okay, ACE inhibitors end in pril, end in pril. ARBs end in sartan, sartan. Captopril has sulfur, so you can't take it if you have a sulfur allergy. Some of these you take twice a day. Others of these you just take once a day. Most of these are in generic now. They're very cheap. Lisinopril, for example, month supply of lisinopril is $2. Very cheap, very inexpensive. These drugs tend to be a bit more expensive, but they're not terribly expensive. Most of these are also in generics, and they're really not that expensive. You usually use these if a patient can't tolerate an ACE inhibitor. Excuse me. So you get vasodilatory benefits. You get reduced peripheral and systemic vascular resistance. Kidneys work better. You get increased diuresis. You get reduced blood pressure, but you don't get rebound tachycardia. That's one of the beauties of these drugs. With many vasodilators, you get rebound tachycardia, not with these. Heart rate is unchanged. You don't get any change in cardiac output. So you can still exercise as much as you want. You don't get exercise intolerance like you get with beta blockers. The one that you need to really watch is hyperkalemia. Now, the hyperkalemia, if your patient hydrates well, is usually not a problem, but it's worth watching. Cough is seen in probably 20% of patients who take an ACE inhibitor, although some clinicians have told me it's probably higher than that. So this is a pretty common side effect. It's not nearly as common with ARBs. Hypotension, dizziness, that tends to be a first dose effect. That tends to go away. Headache, that also tends to go away. Angioedema is the one severe side effect you need to watch for. You will usually see that within the first month or two of taking the drug. After that, it's usually not an issue. Angioedema, word on angioedema, tendency to be a high risk for angioedema tends to be inherited. So if a parent had an angioedemic response to a drug like this, the kids have a higher risk of having that. So getting a good medical history is a good idea. ARBs, angioedema risk is low, cough is low. ARBs basically, hyperkalemia is the one thing you need to watch for with ARBs. They are very, very well tolerated. Big thing to note about these drugs. Number one, they're contraindicated during pregnancy. They cause fetal malformation of the kidneys. They're contraindicated during pregnancy. However, during breastfeeding, they tend to be secreted into breast milk at very, very low levels. So after the woman has given birth, she can go back on them. If the patient, and Greg, this gets back to your question, if the patient's on something that increases potassium levels, then you really need to watch potassium levels. Now, potassium levels will definitely soar. NSAIDs. You should not take ACE inhibitors or ARBs with NSAIDs. NSAIDs will tend to negate the effects of these drugs. Acetaminophen is fine. NSAIDs, you don't want to combine them. Now your ACE inhibitor will stop working. And you can give other drugs that will lower blood pressure, and you can add effects, but your chances for hypotension go up. So these drugs are used virtually universally in patients with diabetes mellitus because they're renal protective. They're one of the pillars of treatment of heart failure. And they're particularly good in post-heart attack with systolic dysfunction because they decrease preload and afterload. Well, excuse me, afterload. They mainly decrease afterload. It's very clear that they benefit patients with diabetes. They prevent the kidney from experiencing the effects of diabetes mellitus. And if you have renal insufficiency, they can help stabilize kidney function. They're very good for that. You want to be careful. In fact, you probably shouldn't use them if your patient has renal artery stenosis. Stenosis refers to narrowing of vessels. Some people get atherosclerosis of the renal artery. That narrows the renal artery. If you have that narrowing of the renal artery and it's severe, then these drugs are probably contraindicated. If you have pre-existing kidney dysfunction, and the degree of dysfunction is going to depend, then you want to use these with caution. They're contraindicated in pregnancy, history of angioedema, and people with hyperkalemia. And then, of course, we could say here, in African Americans, they're probably not going to work as well. However, they are used in African American patients who have congestive heart failure. Questions about these drugs before we move on? Okay. Calcium channel blockers. We didn't talk too much about these drugs before. You have a list of calcium channel blockers in your notes on page don't worry, I'll find it. I'll find it. Oh, sweet. Come on, where are you? I just saw you this morning. Oh, here we go. Page 39. Now, your calcium channel blockers come in two flavors. There are the dihydropyridines, and that group is mercifully abbreviated DHPs. So if we call them DHPs, does anyone object? Nah, let's call them DHPs because dihydropyridines, your tongue tends to get dead after a while. So the DHPs, and then there are these two others. These two others are antiarrhythmic drugs. So these are class 4 antiarrhythmics. There's two of them, diltiazem and verapamil. Those are not used for blood pressure. The ones used for blood pressure are the DHPs, the DHPs. Now these are going to address the L-type calcium channel, the L-type calcium channel. So let's go over to our little makeshift blackboard here if my computer behaves, which is not guaranteed these days because Zoom seems to just chew up all my internal RAM. There we go. Oh, we got a nice bit of sunlight coming in here. And it's making me blind. Okay, so if this is a smooth muscle cell, and this is a smooth muscle cell, let's say in a blood vessel. So the blood vessel then, there'll be your endothelium here like this. And then out here, you'll have your out here you'll have your adventitia out here. So these cells are going to have a channel This channel is a voltage-gated calcium channel, and this is the L-type calcium channel. The L-type calcium channel. Now, when this cell experiences depolarization, typically because of either nerve impulses or it could be a mechanical impulse, because if the vessel gets stretched, stretching can also act as a activation of this channel. This will open, calcium will enter the cell, and the cell will contract. So, what do you think happens if you inhibit this channel? Just guess. It doesn't contract, so you get vasorelaxation, vasodilation. Because now those smooth muscles, those vascular smooth muscles, will relax. SM, smooth muscles, relax. That essentially is the function of the DHP calcium channel blockers. So let's go back to our slides. So DHPs are specialized for vascular smooth muscles. They cause vasodilation, therefore they cause decreased systemic vascular resistance. They cause decreased systemic vascular resistance. And the dihydropyridines are prescribed for blood pressure. Now, typically with these drugs, if you're going to use them for blood pressure, you always prescribe extended release preparations. The extended release preparations are better tolerated, last longer, and are much more effective. So here are some of the ones, and notice these are going to end in dipene, dipene. So think of the calcium channel blocker, looks like 2 pine trees. Those 2 pine trees, then calcium comes through, let the pine trees get close together. 2 pine trees, dipene, 2 pine trees. Okay, Corinne's looking at me to say, okay, you're just nuts. I need to call the funny farm. You've lost it. You're going to remember it though, aren't you? 2 pine trees, dipene. Those are your calcium. The glare on that is awful. Yeah, let's, oh, that's what it's just me or is the glare really bad? That's better? Yeah. Okay, Corinne, if it's bad, say something. We'll shut these off because, so these are your dihydropyridines. Nimodipine. Nimodipine is used for subarachnoid hemorrhages. Subarachnoid hemorrhages. Who knows what a subarachnoid hemorrhage is? When a spider gets a headache, huh? That's a nice guess. So the meninges of the brain, there's 3 layers. There's the dura mater, which is right up against the bone, and it's kind of sort of an extension of the bone in some ways. Then there's a little spidery arachnoid mater, and then the pia mater. And the arachnoid mater contains blood vessels. If those blood vessels leak, blood gets pools in the arachnoid space, subarachnoid space. You start to get pressure on the brain. This is a very dangerous situation. You can get a brain herniation in that case. You get what's called a thunderclap headache. This is ringing headache that comes on like that. It's a very dangerous situation. You have to treat this in a hurry, or you're going to fall into a coma that you'll never come out of. Nimodipine can be injected into the ventricles, and it prevents the spasming of the vessels that feed the brain under those conditions. It's very useful for that, and that's used for subarachnoid hemorrhages. Nimodipine. The rest of these, as you can see, are used for hypertension. They're given orally, and most of them are pretty well tolerated. You're right about the headache. Definitely right about the headache, just the spider part, not quite right. Okay, these 2, as we said, these are antiarrhythmics. These block L-type calcium channels in the heart. In the heart. DHPs in the vessels. These in the heart. Now, diltiazem kind of does a little of both, but it's mainly used as an antiarrhythmic. It's not used as a blood pressure med, although it lowers blood pressure. Okay, some of these drugs will increase the heart rate. Some of them do this worse than others. Amlodipine is probably one of the biggest offenders. That's why you use an extended release form of amlodipine, and it doesn't cause reflex tachycardia that's nearly as bad. They will increase stroke volume because of the vasodilation. You're going to dump more fluid into the heart, so you'll increase cardiac output to some extent, but they will decrease your systemic vascular resistance because of vasodilation. So if you activate these channels, you get this. However, the calcium channel blockers will reduce these parameters by preventing the activation of those L-type calcium channels. Now, the big side effect of these is that they can cause peripheral edema. So they can cause swelling in the ankles. They can cause some swelling in the fingers and what have you. That's why you use the extended release forms. That tends to mitigate a lot of these effects. Reflex tachycardia depends on the drug. Flushing and headache tends to be a first dose effect that tends to go away. However, if you're prone to headaches, these drugs can make them worse. They can also cause some hypotension. We will get to non-dihydropyridines at a later time, and I'll talk about those when we get there. So they're quite good for isolated systolic hypertension. They're very good for angina. They can be useful for atrial tachyarrhythmias. That would be the case especially for the non-DHPs. They work very well in patients with diabetes. And they play nicely as well with other antihypertensives too. People who get organ transplants, they're on a anti-rejection drug sometimes called cyclosporin. Cyclosporin can tend to raise blood pressure, and calcium channel blockers treat cyclosporin-induced hypertension very, very effectively. Any questions about calcium channel blockers? Remember, they end in di-pine tree, 2-pine tree, dipene. Okay, so if we are treating people for high blood pressure, if they're not at the goal, and this is the JNC7, so these are the old ones. Now today, that would be 130, and that would not be 90, it would be 85. So you're going to essentially recommend lifestyle modifications. I have in your notes the outline for the DASH diet, the diet to arrest systolic hypertension. The DASH diet is very bland. Some people can't stay on it, but the DASH diet has been tested against medication. The DASH diet in most people does work. So if you decrease intake of sodium, you can decrease hypertension. That is clear. Now, some people have hypertension that has nothing to do with their sodium intake. DASH diet will just tick them off because they'll eat tasteless food for a couple of weeks. Another diet I do not have in there that's been shown to be effective for hypertension is the Mediterranean diet. There's now Mediterranean diet cookbooks you can buy. And I see Jessica nodding her head. Of course, you're Lebanese, so you're that's your wheelhouse culinary-wise. These diets, some of you will see patients who struggle with this, recommend this. Recommend this. In fact, have in your repertoire, have cookbooks in mind that you can, or have them in the office. You can just show them and say, I have no proprietary interest in this, but here's a cookbook. Good. low sodium diets, the food even tastes good, and you can cook with low sodium and so on and so forth. Recommend these things to your patient. If that doesn't work, then it's time for medication. So without compelling indications, then stage 1, hypertension, you'll start either ACE inhibitor or sartan, beta blocker, calcium channel blocker, or you may need a combination thereof. For stage 2, usually you'll need 2 drugs. Almost always you start with 1 drug and then layer on the other drug as well. Many of these drugs come in combinations. They come already as combinations, so the patient just takes 1 pill, which is very convenient. If you have compelling indications, such as diabetes, such as renal disease, such as decreased liver function, heart attack patients, something like that, then you need to match your antihypertensive with the compelling indication. Now, this gets back to a question that JP asked on Monday. Why were the levels essentially revised? And it had to do essentially with these data that came from the JNC7 continued study. You can see here, even in the old normal range, if you look at the lower blood pressures, both in men and women, as you trace them years out, look at the difference in cardiovascular events. That's a significant difference. That's why these levels were ratcheted down, essentially, because it was clear. It wasn't clear at first by ratcheting them down that there was been a clinical benefit. Now it turns out it's very clear from these data that there is clinical benefit. So by controlling blood pressure aggressively, you can significantly reduce the probability of a cardiovascular event as time goes on. So if you have some sort of compelling indication, so for say heart failure, beta blocker, diuretic, ACE inhibitor, or ARB, aldosterone agonist. Oh dear, I misspelled agonist. Sorry, just pretend that S isn't there. And you can see these are going to be part of that 4-pillar treatment for heart failure. Post-myocardial infarction, ACE inhibitor almost without mentioning, and then beta blockers is clear post-MI are cardioprotective. If you have a patient at high risk for coronary artery disease, say they have angina or something like that, then a non-DHP or a beta blocker will be the indication. Usually also maybe an ACE inhibitor and maybe a diuretic to decrease the preload and the afterload. Diabetes, essentially, ACE inhibitor definitely. If you use a beta blocker, you better make sure and use a cardioselective one. And then diuretics work very well in diabetics as well. And then if you have an arrhythmia, a non-DHP calcium channel blocker is also a possibility as well. If you have chronic renal disease, now your diuretics are a problem, but ACE inhibitors now can be renal protective, or ARBs can be renal protective. And then if you have a patient who had a stroke, you're trying to prevent them from having their second stroke. Remember, arrhythmias can throw clots. Those clots can produce a second stroke. These 2 drugs here are part of your required medication armamentarium for people for whom you're trying to prevent a second stroke. Diuretics of some sort and an ACE inhibitor. Josh.
So what should
If an African American has chronic renal disease, one of the drugs you would put them on usually is an ACE inhibitor to protect the kidney. It'll be a low dose ACE inhibitor or ARB. And then if they have hypertension, African Americans respond extremely well to diuretics. They also respond very well to calcium channel blockers. They also respond really well to a drug called Diil. It's a combination of hydralazine and isosorbide mononitrate. I'll talk more about that when we talk about angina. But that drug combination works extremely well in African Americans. And it's a vasodilator. Hydralazine is a vasodilator. Still, nobody knows how it works, but it causes vasodilation and it lowers blood pressure. It's used a lot for emergencies in hospitals, hypertensive emergencies. This is just a little ditty about cost of drugs. You can see when you compare the name brands to the generics, you can see that the cost difference really starts to get acute. Fortunately, most of these are in generics. And your algorithm is basically, if you don't get success, keep layering on drugs. And then this is just a chart for some of your special indications for pregnancy. Pregnancy, your mnemonic is hypertensive mothers love nifedipine. Hypertensive mothers love nifedipine. Hypertensive H, that's hydralazine. Mothers, M, methyl-dopa, love labetalol. Nifedipine is nifedipine. So nifedipine is the calcium channel blocker of choice. You avoid ARBs like the plague. So yeah, that's just something to look at. And then these are just the risks of hypertension. And yeah, okay. We finished this. We will continue on next time. I think the next section is hyperlipidemics, if I'm not mistaken. Yeah, no. Treating angina, Okay.
So nothing from Monday is going to be on the
No.
But you guys was just
Yeah. That's there. Okay. Thank you.